I'm Adil Daud. I'm going to be talking today about recent advances in melanoma therapy. And I'm a clinical professor of medicine and co-director of the melanoma program at University of California, San Francisco. And my topic today is to discuss some of the recent advances in melanoma. There's been an incredible amount of advances lately in melanoma, and some of these advances have been in the news media, and here's just a small collection of headlines. Melanoma and immunotherapy have been all over the press, and these are shots from the Los Angeles Times and from the New York Times and from Nature, talking about some of these new drugs and the breakthroughs in melanoma that we've seen with these new drugs. If you look at skin cancer overall in the United States, there's a lot of cases of skin cancer, and if you especially look at the incidence of skin cancer, there's over 3 million cases of skin cancer in the United States. And those include basal cells, squamous cells, melanomas, and a rare kind of cancer known as Merkel cell. The most common kind of skin cancer is actually basal cell cancer, and there's over 2.8 million basal cells in the United States in a year. So that's actually more common than any other type of skin cancer. Squamous cell cancers are also pretty common. There's 0.7 million or 700,000 squamous cell cancer cases in the United States in a year. And then if you look at melanomas, it's actually a relatively unusual type of skin cancer, and there's 60,000 cases in a year. If you look at the deaths, though, from melanoma, they are way in excess of any other type of skin cancer. There's 8,000 patients dying of melanoma, while only a few thousand from squamous cell cancer, and almost nobody dies from basal cell cancer. There's 600 deaths from Merkel cell cancer, which is a very rare kind of cancer that we think has viral causation. It's interesting for me to look at this map of the United States and look at cancer mortality rates, focusing on just white males from 1970 to 1994. And if you look at just white males, it's interesting that the highest areas of cancer mortality from melanoma are in the southern part of the country. And if you look at the southern part of the United States, that's where most of the melanoma deaths occur. You'll notice that in places like Wisconsin and Minnesota, there's actually a very small number of white men dying from melanoma. While if you look at Georgia and Mississippi and California, Texas, Florida, and the Carolinas, that's where most of the cancer deaths are concentrated. So it kind of gives you a flavor for what's going on. And I think this is a complex question, and people talk about ultraviolet radiation, but also it's important to remember that even though people were going out to the beach, in the 30s and 20s, people were a lot more covered. And I love this picture, which was taken at the beach in New Jersey in the 1930s. You see that guy there with who's sleeping with his tie on and shoes on, and that's the way people were at the beach. And if you look at people at the beach today, of course, there's a lot more. There's a lot less clothing to protect you from the sun. So I think it's a complicated question, but certainly we are getting exposed to a lot more ultraviolet radiation today than we used to in the past. So one of the crucial breakthroughs in melanoma research really came in the early 2000s when my colleagues here, Boris Bastian and others, and many other investigators around the world, including Helen Davies in Britain, showed that if you look at cancer, and if you look at melanoma specifically, where the melanoma comes from seems to determine the likelihood of specific mutations. So for example, if you look at eye melanomas or uveal melanomas, almost none of them have a mutation in BRAF, and about 80 to 90% have mutations in these G proteins called G11 and GNAQ. If you look at melanomas in the trunk or in the lower extremities, a lot of those melanomas have mutations in BRAF. About 60% of them almost have mutations in the BRAF gene. And if you look at melanomas occurring in the mucosa, very few of them have BRAF mutations. And similarly with melanomas from the nails or from the feet or hand, what are known as acrolentiginous melanomas, very few of them have BRAF mutations. So just giving you an idea, just giving you a flavor for the mutation status varying depending on where the melanoma arises. If you look at signal transduction map of the cell, you'll notice that if you plot a lot of the frequent mutations in melanoma, a lot of them map to what's known as the MAP kinase pathway. So a lot of mutations are in either BRAF, which is right here, or MEK, which is right here, or NRAS, which is right here, or in what are known as P16, which is right here, and right here, P21 and P16, and some of the other mutations are in this PI3 kinase pathway right here. And so if you just map them out, you'll realize that a lot of them are downstream of growth factor signaling, especially in the MAP kinase pathway. And that's given rise to this idea that if you were to block this MAP kinase pathway, you get some mileage from melanoma treatment. So just to move gears a little bit to more clinical outcome data in melanoma, if you look at melanoma survival by stage, you'll notice that, of course, stage 4 melanoma is associated with very poor survival. And if you look at stage 4 melanoma, and if you look at the 50% survival, that's right over here. That's generally a year or less. But even if you look at the stage 1 melanoma, so you're talking about very thin melanomas, you'll notice that if you look at the 5-year survival, which is right here, you'll realize that it's approximately 90%. And if you look at the 10-year survival, it's maybe about 85%. And if you look at the 15-year survival, it's even less than that. So just giving you an idea that melanoma survival, even in very thin lesions, does not plateau. So over time, you'll have some patients who die of melanoma, even with very thin melanomas, even beyond the first 5 years, which is different from other types of cancers where, if you've made it to 5 years, you're probably good to go. So one of the early advances in melanoma was the technique of sentinel lymph node biopsy. And here's slides that were provided to me by Dr. Douglas Rankin, who's at Moffitt Cancer Center. And he and many others pioneered this technique where you would inject a dye, a blue dye, around the site of a primary melanoma, and then track it to the regional lymph node, take the lymph node out, look at it microscopically, and if that lymph node had melanoma in it, then that patient was considered to be stage 3 versus stage 1 if that lymph node was negative. And so the sentinel lymph node technique really revolutionized the staging of melanoma. So now we can tell with a lot of accuracy whether somebody has a stage 1, stage 2, or stage 3 melanoma. And that makes a big difference to prognosis and helps us to plan who needs to have further treatment. And here's a photo micrograph showing that same sentinel lymph node from the patient shown earlier, and just showing that if you look at this patient, you could see that this patient has a focus of melanoma cells that you can see on the H&E section on the left-hand side. And then when that section is stained by S100, you could see that that stains positive for S100, indicating that this is a little focus of melanoma cells in that lymph node, so showing that this patient had stage 3 melanoma. So what can we do for melanoma that's spread to the lymph node, and how can we prevent that melanoma from coming back? Because we know that a certain proportion of those patients will go on to develop systemic melanoma and die, right? So some of the treatments that have been studied are interferon alpha, either native or pegylated, which is a newer form of interferon alpha, vaccines, GM-CSF or granulocyte macrophage colony stimulating factor, and also this drug called ipilimumab. And I'll just talk briefly about all of these different options. So the first treatment, and the treatment that has a lot of clinical trials and has been studied extensively in melanoma, is this drug interferon. Interferon was discovered in the late 1950s by investigators in Japan who found that interferon prevented or protected from influenza or from viral illnesses. And subsequently, interferon was treated in cancer. It was treated in a lot of different indications, including hepatitis C. And in melanoma, particularly, it's been extensively tested from the early 1990s, actually. And the first, most important trial that was done was the ECOG trial 1684 by John Kirkwood, and multiple other trials, as you can see in this meta-analysis. So the one thing that seems to stand out for interferon that very few people dispute is that interferon definitely reduces the recurrence rate of melanoma, and this meta-analysis just points to that. If you look at the hazard ratios for interferon, you can see that almost every interferon trial favors the addition of interferon in terms of reducing response rate. And you can see that all of these trials are on the left side of the one hazard ratio showing favor interferon. Only one trial did not favor interferon in terms of recurrence-free survival. So that part is absolutely without question that interferon reduces recurrence. But the more difficult question is, does it improve survival? And this just shows that, again, if you look at interferon, either high dose, intermediate dose, or even low dose interferon, you'll see a reduction in recurrence. The problem is where you try to see and try to establish if interferon improves survival. There, the picture isn't very clear. Here you can see that some trials do favor interferon in terms of overall survival. You can see that ECOG 1684 favored interferon for survival, but a lot of the trials cluster near the one line, basically showing no benefit or a slight benefit at best. And if you put this together mathematically, you can see that the hazard ratio is much less impressive for survival than it was for recurrence. And you can see that for recurrence, the p-value is highly significant, while for survival, the p-value is not very significant, and depending on what trials you include and what trials you exclude, you can see a benefit, either a small benefit or sometimes even no real benefit. So other treatments that have been tried in the preventative setting include GM-CSF, vaccines, and ipilimumab. And I think today there isn't a lot of data that either one of them will prevent relapse or help overall survival. I think there's in fact some data that vaccines, at least some vaccines, might even worsen survival. And again, with ipilimumab, trials haven't been reported, but there isn't a clear signal that ipilimumab helps in terms of recurrence. So right now, most people do not recommend using ipilimumab for survival, for in terms of adjuvant treatment of melanoma. Now, what about stage 4 melanoma, metastatic melanoma, where that's the more heavy-duty melanoma, where the tumor may have spread to your lung or liver or lymph nodes or some other place beyond the regional draining lymph nodes? So until 2010, almost every randomized trial in melanoma was negative, and this just shows some of the trials, dacarbazine versus temozolomide, that trial was negative. That's this trial here, EORTC 18032, carbotaxol versus carbotaxol plus sorafenib, also negative. PRISM, which was the same trial but in the second-line setting, negative. Dacarbazine versus tremelimumab, which is a CTLA-4 antibody, again, that trial was negative. GP 100 versus ipilimumab was positive, and so that's an outlier. But dacarbazine versus dacarbazine plus oblimersen was negative, and the BEAM trial also was negative. So really, except for this MDX010 trial, every trial prior to 2010 was negative, and people despaired of if any treatment in melanoma would ever show survival benefit. So imagine everybody's surprised when Keith Flaherty and his colleagues reported on BRAF mutant melanoma responding extremely well to a new BRAF inhibitor. And this was reported in a couple of papers in the New England Journal of Medicine and in Nature, published in August 2010, showing drastic efficacy. And this is just to give you a flavor of that response rate. This is a patient who had a PET scan at baseline and by day 15, and you can see that even by day 15, a lot of his tumor had, so like you could see that his lymph node disease here is remarkably improved. His axillary lymph node disease here is almost gone. You could see that this is a patient who had tumors in his liver and lungs, and you could see that his liver now looks almost without any disease here. If you look down at his lung nodules, they're gone by 8 weeks. Liver lesions are extremely reduced. Like, look at this lesion. Now it's less than half the size, and this is all within 8 weeks. And the remarkable response rate that was reported in this study was a overall objective response rate of 81%. So unprecedented for melanoma. And this just shows the response rate by waterfall plot. So you can see that all of these patients here, all of these patients here had tumor shrinkage. So you could see, really, except for this one patient here who had tumor progression, and this patient here who had a little bit of tumor progression, everybody else had shrinkage of disease. So remarkable for a melanoma trial. I think previously, if you looked at melanoma trials, you'd see maybe some patients here respond, but everybody else would have progression of disease. So just remarkable results. So once this BRAF inhibitor showed such great responses in phase 1, it was tested in a phase 3 trial where patients were randomized to vemurafenib, which is the BRAF inhibitor, versus dacarbazine, and 675 patients were randomized in this study. And what they showed was, again, remarkable responses, and this is just the most updated data on that trial. You could see that the response rate with dacarbazine was only 8.6%, while you could see that the response rates to vemurafenib were 57%. And so just a major difference in objective response rate. And if you looked at progression-free survival, there was a major difference also. Dacarbazine only 1.6 months, vemurafenib 6.9 months, so almost a 5-month difference in progression-free survival. Now, objective response was high, progression-free survival was extremely good, but overall survival not as impressive. There was a 4-month difference in overall survival, 9.7 months for dacarbazine to 13.6 months for vemurafenib. If you looked at who responded best, you could see that almost everybody responded better with vemurafenib versus dacarbazine. The only patients who had showed any real ambiguous results were the patients with stage 3C melanoma and some of the patients with stage 1A melanoma. Everybody else, men, women, older people, younger people, low performance status, high performance status, everybody did better with vemurafenib. So people thought, well, if you could get a lot of mileage with BRAF inhibitors, which work here, maybe you could get even more mileage with BRAF plus MEK inhibitor, which would block this pathway at 2 different levels. So it's kind of like blocking a river 2 times. So a river might overflow 1 dam, but 2 dams, that's going to take more time. How about that? There's some preclinical support for this idea, and in animals, you could see that if you give a BRAF plus MEK inhibitor, you can get much more mileage. That's that line over here, the last line in red, showing that tumors can grow, untreated tumors grow rapidly in a xenograft model. If you give just the MEK inhibitor, that's the orange line here, trametinib, tumors still grow pretty rapidly. If you do dabrafenib, which is the green line, they grow rapidly. But if you do both together, you can pretty much suppress tumor growth, and that's that red line here all the way up to 90 days. So we and some of my other colleagues, including Keith Flaherty, explored this in a trial, and we reported this last year. And what we showed is that, again, a tremendous difference. So you could see that if you do just the BRAF inhibitor, that's this line here, that shows actually I take that back. If you do just the BRAF inhibitor, that's this line in yellow, and that's the monotherapy arm. And if you do the combination of BRAF plus MEK at the high dose, that's this green line here. So you could see that the difference in median progression-free survival changes from 5.8 months for monotherapy dabrafenib versus 9.4 months to the combination. And dabrafenib is a BRAF inhibitor that's made by GlaxoSmithKline. It's now approved for treatment in melanoma, and it's a different drug from vemurafenib. And in this trial, it was combined with trametinib, which is a MEK inhibitor. So showing a major difference, progression-free survival with the combination in this randomized phase 2 trial. The waterfall plot, very impressive, again showing most patients benefiting greatly, only a smattering of patients showing any type of progression. So with that, let me turn your attention to immunotherapy. And immunotherapy does have a long history in melanoma. We talked about interferon, which is a type of immunotherapy that works on innate and adaptive immunity. And so one of the major advances in our field was ipilimumab, which we talked about a few slides ago. And it's an anti-CTLA-4 antibody. And so this next set of slides just reviews the mechanism of action of ipilimumab and another immune therapy antibody called PD-1, and we'll just walk through the mechanism of action of these antibodies. So if you look at a tumor cell, when a tumor cell has what we call immunogenic cell death, what will happen is that little fragments of tumor cell will be ingested by an antigen-presenting cell or a dendritic cell. And then this dendritic cell presents these same antigens in the context of the major histocompatibility protein on its surface, MHC, which docks to what's known as a T cell receptor, TCR. And then that, along with what we call signal 2, which uses a co-stimulatory molecule to bind to CD28 on the T cell, and that connection, the signal 1 and signal 2, is what stimulates the T cells. And then once these T cells are stimulated, then the T cells will then go and kill tumor cells, again recognizing the tumor cells with the T cell receptor right here. So that's how the immune system works. Now there's many levels at which the immune system can be turned down. One level that can be turned down is through what's known as a PD ligand, PD-1 pathway, where tumor cells can produce PD ligand or PDL1, which is kind of a don't eat me signal, where tumor cells tell T cells, hey, don't attack me. And T cells, they kind of turn off the immune system that way. And so if you prevent that pathway from being engaged with a PD-1 antibody like nivolumab, which is a Bristol Myers Squibb PD-1 antibody, or MK3475, you can actually keep the T cell from being turned off and get the T cell to kill your tumor cells. Or you can prevent this pathway from engaging and or prevent CTLA-4 from competing with CD28 and turning off signal 2, and that way you can get more T cell activation. So you can affect this pathway at multiple levels, but especially at these two levels, CTLA-4 or PD-1. And I want to present some of the data that we have on PD-1 that has been recently presented both in the New England Journal and also at our melanoma meetings. And one of the most exciting has been this PD-1 antibody. That's the Merck PD-1 antibody, MK3475, recently published in the New England Journal. And this slide just shows the waterfall plot, again showing major response and showing that all of these patients here had tumor shrinkage, which in the context of BRAF inhibitor therapy and BRAF and MEK inhibitor therapy doesn't sound as impressive, but for immune therapy, that's unprecedented. That's just an amazing response rate. Most immune therapies, you'll see response rates in the 10% to 20% range. Just seeing response rates in 30% or 50% of the population is pretty amazing. And this slide gives you an idea of how long-lived these responses are, and it's what's known as a swimmer plot. So here patients are developing response right around 10 weeks, and then you can see that these blue arrows show ongoing responses. So you can see that almost everybody here has ongoing responses, and you can see all of these blue arrows here. These patients have progressed, but everybody else is ongoing responses, showing that even up to a year, most people have ongoing responses, and pointing to the fact that immune therapy generally produces very long-lasting responses. Here's the data for lambrolizumab, or MK3475, which is a PD-1 inhibitor, and just showing that at the very highest dose level, that's 10 milligrams per kilogram given every 2 weeks, patients who were ipilimumab naive had response rates of 56%. Patients who were treated also the same. And if you looked at the 10 milligram per kilogram every 3 week response rate, it's somewhere between 30% to 22%, depending on whether patients were naive or treated. And at the lower 2 milligrams per kilogram dose, responses were in the 14% range. If you look at naive versus ipi-naive versus ipi-treated, you don't see a huge difference, kind of pointing to the fact that response rates don't really seem to vary depending on whether patients have had ipilimumab before or not. Additionally, one of the interesting things in that trial was that response rate, either by central review or by investigator assessment, don't seem to be a lot different, so showing pretty much the same response rates in either case. I'm going to skip through the next few slides. Here's some of our patients who've been treated, and I just to give you a flavor of responses. So here's a patient who had lung metastases, and you could see that most of these lung metastases have completely regressed, and just shows you that this is a patient who at 12 weeks apparently showed progression with this new tumor that showed up in a hilar lymph node that you could see right here, and that by 24 weeks that tumor was gone, and also her other lung mets were gone. And here's a patient who had tumor not just in the lung but also tumor in the bone, and you could see that by 24 weeks the tumor both in the lung and bone was almost disappeared, and it just shows the CAT scan showing a great response. And this is a patient who had innumerable lung lesions. You could see, multiple in both lungs, and you could see that they're pretty much gone by week 12, and then she's had a complete response subsequently to treatment. Here's a patient with desmoplastic melanoma. It's the kind of melanoma that's aggressive locally, and you could see that his melanoma was so advanced that he could not even close his eyes, and you could see here that his eye was totally shut because of the melanoma affecting his eye. And you could see that after he started treatment, he had some regression of tumor, ultimately was able to open his eyes after 9 weeks, and has continued to have a nice response. Now, one other major development in our field has been this study that was presented by Jed Wolchok and his colleagues, and also published in the New England Journal of Medicine, of nivolumab, which is another PD-1 antibody made by Bristol, along with in combination with CTLA-4. And this just shows the amazing responses seen with this combination. And again, this is a spider plot, but notice how rapid and how sustained these responses are, where patients have tumor that just shrinks down and then stays shrunken down. And you could look at from the waterfall plot that a lot of patients appear to have great responses. And this is a patient with lymph node disease showing nice responses. what Volchok and colleagues did is they tested several different doses. They tried nivolumab at a lower dose along with ipilimumab at a higher dose, or other permutations and combinations. And if you look at their response rate, it just basically shows that the highest response rate they got was at the nivolumab 1 milligram per kilogram, ipi 3 milligrams per kilogram, which was right here, 53% response rate, 65% clinical activity. So quite an unprecedented number for an immunotherapy trial. If you compare lambrolizumab, which is the Merck antibody, with nivolumab plus ipilimumab, which is the Bristol antibody, you could see very comparable numbers. So in the combination study, you could see that there was 53% partial responses in the highest dose level of the MK3475 study, 56% response rate. So comparable numbers. I think one of the questions that remains to be answered is how this will play out in the next few months or in the next few years. So one other area that has been of great interest to me particularly, but also to other people, is using cytokine and cytokine therapy to improve response rates. And we focused our research on interleukin-12, which is a crucial cytokine that's used by neutrophils and macrophages, dendritic cells, to signal to T cells. And so this is a different kind of signaling which does not involve the T cell receptor, but this is a cytokine that increases proliferation, increases signaling at the T cell level. And so what we've done is we've actually used a gene therapy approach where if you look at a melanoma tumor, that's right here shown on the left-hand side, you can basically inject your plasmid right into the melanoma tumor, and then using an electrode, you basically insert needles into the tumor, and then with a short duration electric pulse, go ahead and pulse that. Here's my colleague Rich Heller, who did experiments in mice initially and showed that this approach worked great in the B16 model, and that's me many years ago, and that's the apparatus that we used in the lab. And here's one of the patients we treated many years ago. This was patient number 9, cohort 3, we've written about this response. But basically, he had a bunch of lesions on his right chest and also on his right back. So those are the lesions on his right chest, and those are the lesions on his right back. And that's how it looked like pre-treatment. We treated 4 lesions, so we didn't treat all of them, just 2, 3, 4, and then one other lesion that's not visible in this photograph. You could see that about 9 months later, a lot of the lesions flattened out and kind of lost some of their volume. And you could see that even on his back, there was some pigment changes and some redness around the lesions on his back. And by year 2, lesions had flattened out, and all you could see is some tattoos. And the lesions on his back also were pretty much gone by this time. You could see that he also had a seborrheic keratosis, which was not changed by this treatment. And you could see that, and we actually biopsied some of these tattoos and basically found that they were just dead cells in there. So with that, I want to conclude, and I think the take-home message is that this is a time of unprecedented advances in melanoma therapy. We've seen great advances in targeted therapy with BRAF inhibitors that are now a primary choice for treatment of BRAF mutant melanoma patients. I think one of the points that I didn't mention but needs to be emphasized is that BRAF inhibitors only work for BRAF mutated patients, and so testing using an FDA certified assay is essential, or a clear certified test is essential. So you don't want to treat BRAF wild type patients with BRAF inhibitors. We don't think that that's helpful and may even be deleterious. The problem with the BRAF inhibitors is that resistance to the therapy develops usually between 6 to 8 months afterwards, and you can add MEK inhibitors to BRAF inhibitors that will give you some extra mileage, but still resistance will develop to treatment. Also, this is a time of great advance in immunologic therapies, and especially therapies like ipilimumab, and this year the PD-1 antibodies have shown remarkable activity in melanoma. with responses higher than 50%, in greater than 50% of patients, and these responses are long-lived, unlike the BRAF inhibitor therapies. Although you cause shrinkage in a smaller number of patients, you do certainly have much more long-lasting responses with immune therapies. Today there wasn't time to cover this, but anti-angiogenic drugs and chemotherapy drugs also have a role in some patients, although today they're becoming third or fourth line therapies in general. With that, I'd like to conclude my talk and then take any questions if anybody has any. Thank you. To get any your CME credits, please go to www.bioconferencelive.com/CME-CE. So one of the questions that's come in is, are mutations in NRAS and BRAF mutations mutually exclusive? And the second part of that question is, and if this is true, will that cause modifications to treatment? So that's a great question. And I didn't talk about that, but yes, it's true that they're pretty much mutually exclusive. So that's actually one piece of data that really made us think that these are driver mutations. And if you look at melanomas, it's very rare for BRAF mutant melanomas to have NRAS mutations also. The one exception to this is when you're treating BRAF mutant melanomas with BRAF inhibitors. Tony Rivas and Roger Lowe and colleagues at UCLA have shown that secondary NRAS mutations can develop in BRAF mutant melanoma after treatment. It could be one of the factors that causes resistance to develop. But up front, it's pretty unusual to have BRAF and NRAS mutations in melanoma. So once you have a BRAF mutant melanoma, most people will assume that you can't also have NRAS mutant melanoma there. So another question from Najib Lamarzi, and that is, what are the major toxicities associated with immune therapy drugs? So that's a great question too. So immune therapy drugs, I think, as a general rule, have a variety of side effects. And so if you look at interleukin-2 interferon, the side effects from them are usually fevers, chills, sometimes nausea, vomiting, what's known as cytokine release syndrome. With ipilimumab, the immune toxicities are very distinctive and include colitis that can be responsive to steroids, hypophysitis or reduced secretion of hypothalamic hormones, and also liver function test abnormalities and dermatitis. So serious adverse events from these four systems happen in maybe about 20 to 30% of patients. With PD-1, the toxicity profile is much more benign, and it's pretty rare to have serious colitis develop with PD-1. So there's not a lot of cases of colitis reported with that. The one distinctive toxicity of PD-1 is pneumonitis, and a few cases of pneumonitis have been reported, and many of those are in patients with lung cancer or non-small cell lung cancer, but some cases have been reported with patients with melanoma as well. Muscle soreness, muscle stiffness, joint aches, joint pains, fatigue, but overall the incidence of serious side effects is much lower with the PD-1 drugs than it is with ipilimumab. So another question that's come up is there any correlation between monocyte macrophage apoptosis and PD-1, PD-L1? I'm not sure. I'm not sure how much data there is on this, and actually I'd have to look and see if there is a correlation between macrophage apoptosis and PD-1, PD-L1 expression. I think people think that stroma contributes a lot to the PD-L1 staining. So PD-L1 staining, although in the slide I showed you, seems to be localized on the tumor cells exclusively. That's probably not true. That's probably simplistic. We think there's a lot of stromal expression of PD-L1, and so the tumor stroma may contribute some to dampening the immune response. And there's data that tumors in different places in the body have a different expression of PD-L1, also different types of tumors, like melanoma compared to lung cancer or colon cancer, have different expressions of PD-L1. And so I think stroma contributes a lot to that. So another question is from someone who says, I'm a 10-year survivor of GBM. I'm also a cancer researcher. In addition, in 2009, I was diagnosed with psoriatic arthritis. Is it possible that my PSA actually helped me survive GBM? That is, with natural high levels of TNF alpha. Yeah, I think it's possible. It's interesting that patients who are on PD-1 therapy can develop arthritis and myositis and muscle inflammation and vitiligo, which are all autoimmune diseases. And I know that I've had patients who had either some type of arthritis or some type of autoimmune disease reactivate those once they have once they're treated with PD-1. So I think it's possible in your case that there might be some linkage between your psoriatic arthritis and your nice response to GBM. So interesting. I think we are still just uncovering the linkage between the immune system and between these new therapies, and I fully expect that in the next, I'd say, 10 years, people are going to look at combinations of immune therapy and targeted therapy, and also look to see how we can deepen responses to some of these immune therapies. All right, so that's great. Thank you all for listening, and I want to thank the organizers for this opportunity. And with that, I'd like to log off.